Print something off anyway. Okay, here we go.
Careful House, obviously, doesn't it? Qualify.
Okay, good morning, councillors, officers and viewing public, and welcome to this meeting of the Health and Social Care Overview and Scrutiny Committee. May I remind members that the meeting will be webcast for live and subsequent broadcast via the council's YouTube site, and that members of the press public may record and take photographs except where there are confidential and exempt items. Can I remind officers and guests joining us on Teams to please keep cameras and microphones off unless speaking, and please use the raise hand button if you want to speak. And then additionally, note this is for officers and guests in the room to make sure we please speak audibly and directly in the microphones to ensure that the live streaming is clearly audible. I'll just make sure mine's acceptable. Okay, apologies. Can I ask both members and the scrutiny officer if any apologies have been received for the meeting?
No apologies.
Declaration of interest. Can I ask any members if they have any declarations of interest to make? Councillor Moore.
County Services to declare government trustee Birmingham GBT, which provides health services.
Okay, thank you for that. If we move on to item 4, which is the action notes and matters arising. So we've got some action notes to approve from the meeting held on the 18th of October. The first one goes back to the July 19th informal meeting where Andrew Marsh agreed to try to obtain information for a suggested new indicator which measures the length of time for when someone is discharged to assess from hospital and the wait for a care package is in place, and will let scrutiny officers know how this was being progressed. There was a follow-on note to that, and that was there was an informal briefing session held with Andrew Marsh on the 15th of November to discuss the matter, and affirmed that the informal briefing session will be organised with Andrew and a representative from University Hospital Birmingham. Regarding the action note from the meeting on the 20th of September regarding tackling period poverty and raising period awareness tracking report, in response to the issue of girls being absent from school during menstruation, the Education and Children's Social Care ONS Committee have agreed to include this in the work programme, and the focus of the report will be on the learning of good practice which has been identified and how this is being shared with schools across the city. Monica Rosinski is to provide a breakdown of male and female staff who attended the event at George Dixon Academy, and this was informally circulated to members of the committee on the 9th of November. Actions from the 18th of October meeting from Forward Thinking Birmingham. Further information on the age of young people being placed out of the area and the trajectory of reducing that number, and the number of weeks a patient waits before treatment was circulated to members on the 25th of October. As a consequence of that, a request was put in for further information on the 8th of November. An update on the future arrangements for adult social care performance monitoring. Merrill provided a table that depicts the alleged types of abuse and neglect in the location where it has taken place. This information was circulated to members of the committee on the 21st of November. At which point I shall be asking questions to see what remembered. Okay, so instead of doing that, we'll go on to item 5, which... No. Pardon?
Second point on your action relating to Forward Thinking Birmingham and the age distance of young people being placed out of the area. I think we've had the initial response to that, so I think we should note our concern actually about the extent of this practice, and I think we have requested further information there. But I do think when that comes back, we need to give some serious consideration to what we get, whether it's an agenda item or some particular informal meeting. I don't mind which way, but there's an issue here that I think we were all concerned about the scale of this problem. We needed more information and we needed more oversight over what was been done to sort it out.
Yeah.
I think it was really helpful it was identified that the committee had followed up. That information can feed into the inquiry task and finish group, so we could follow up through that, and it may be that FTB are invited for a future task and finish group meeting for the inquiry to look at that in more depth, and then obviously that can lead to any recommendations the inquiry may want to make.
Okay, so anybody else got any points to make?
Well, on that, I was particularly concerned with the rather large blob that there was around Northampton, because unfortunately that facility has developed a reputation, shall we say, over the last few years of a number of local authority young people that have been on placements there. And I'm particularly concerned about the use of that. But it is general. The lack of facilities for young people who require placements, particularly for mental health issues, are a long way away from Birmingham. And they naturally need the help and support of their family. You know, there was one, I think it was up in Scotland, in Glasgow, you know, impossible.
I know that's a concern I think most of the members of the committee share, and I know myself I've been aware of cases where people have been placed as far away as Glasgow and as far away as the South Coast. And if you've got a family that wants to try to keep in regular contact, which is really important for people who are in a mental health unit, that's really impossible over those distances. And I think we also asked them to get some follow-up information in terms of if somebody is placed a significant distance away, what efforts they make to try to move to a geographically closer placement, or is the plan to actually to keep them in the placement they're actually in. So once we've got that clarification, we'll make sure the committee's aware of that.
I'm just happy to agree the action note.
Yeah. Okay. Are people happy that we agree the action notes that we've flagged up? Yeah. Okay. Thank you for that. So item 5, it's Birmingham Solihull Integrated Care System 10-year strategy. And we have David Melbourne with us. We've got Sue Longden on stand is here on screen. And we've got Suzanne clearly here as well. So I hand over to the two of you. If you look for maybe 20 minutes on the presentation, which gives 35 minutes for questions.
Thank you, Chair. My name is David Melbourne. I'm the Chief Exec of NHS Birmingham and Solihull. And indeed, things that you've just been talking about are of real interest to us in terms of out-of-area placements. It's something that we do focus on in terms of that impact on patients. But we're here today to talk to you about our integrated care strategy for Birmingham and Solihull. I understand that members of the committee have been briefed on what an ICB is and what an integrated care partnership is. We were established in July, the 1st of July 2022, as Integrated Care Board, and we have a statutory committee which is called the Integrated Care Partnership, and that is a partnership between the NHS and local government. Your member on there is Councillor Khan, and she attends those committees. Now, one of the key first jobs of the partnership is to develop a long-term health and care strategy for the system, and it is for both Birmingham and Solihull, because we cover both. When I was thinking through how best we develop that, I asked your Director of Public Health to lead that for the system, and your Chief Exec said that she would allow him to be released to do that. So a lot of the work has been done by Dr. Justin Varney. What Suzanne's been doing is supporting, helping and leading the engagement process in terms of that integrated care strategy. So we're here today, Chair, to present where we've got to on that and get some engagement and feedback. So I'll pass over to Suzanne.
Lovely. Thank you. Hello. It's great to be here today. So thank you all for giving us the time to talk about this. And that timing you've just set out, Councillor Brown, is really helpful. So I'll spend about 15, 20 minutes going through the presentation, because actually, so in the pack, what you'll see is there are some links to a video which just talks about what is an integrated care partnership, what is an integrated care board, because we're conscious that everything's changed again. The language has changed. So there's a video there in different languages that people can go and have a look at, because we're trying to engage as widely as we can on this. So, but I'll just take you through the presentation pack that we've got at a high level, because I'm assuming people will have had the chance to hopefully have had a look at it already. And then the next slide just talks a little bit about who is in the integrated care system. So you can see on this slide a list of the various different partner organisations. So yes, it is NHS and it is the two local authorities, but you can see the voluntary and community and faith sector are well represented as part of the partnership as well, and organisations like the police and the fire service too. So the purposes for the integrated care system are about improving outcomes in population health and healthcare, tackling inequalities in outcomes, experience and access to health and care, and also by working across the system in a more integrated way for NHS and local authorities, we can hopefully enhance productivity and make sure that every pound of taxpayers' money we're getting the most value for citizens and people who need our services. So the next slide just describes the different layers in the system. Again, I'm assuming that people here will be quite familiar with that in terms of Birmingham and Solihull as the system, and then the two places being Birmingham and Solihull, and then obviously within Birmingham we've got the 5 localities within that as well. And that's important when we start to talk about how we want to work in the system a bit later on and thinking about subsidiarity and decision making. So this next slide just talks a little bit about the roadmap, really, in terms of where we're at in developing the strategy. And obviously we're kind of in November now, so we're getting towards the end of the engagement work now. And really what I want to say here is that actually we're not starting from scratch. We're not starting with a blank sheet of paper here. We're building on what we already know. So in developing this, Justin and his team have done a lot of work looking at the joint strategic needs assessments, the population health profiles, the health and wellbeing board strategy, and also importantly what citizens and people who use our services and their families have been telling us about their experiences, as well as people who are working in the system as well. So you can see that we're trying to engage with health overview and scrutiny committees and health and wellbeing boards, as well as a number of like NHS Trust boards as well. The strategy will go to the Integrated Care Partnership Board meeting on the 14th of December. It then has to be submitted to NHS England by the end of December. We're sure that they'll have some feedback and comments. So we think we'll be doing further work in kind of January, February, with a view to kind of firming this up in March in terms of what we want to do. So I'll just move on then to get into some of the detail of what we're talking about. And I know you'll be very familiar with this, so I won't go into this in a lot of detail. But, you know, there's so many amazing things happening in our patch. There's lots going on. We've got the legacy of the Commonwealth Games. We've got hugely super diverse communities, lots of really vibrant things going on. But we also know that we've got some deep-seated challenges in our population, and those don't affect all of our communities equally. So the next slide just sets some of those challenges out. And some of the big headlines here are around that kind of disease inequality. We know that life expectancy is different depending on where you live. We know that infant mortality affects some communities more than others, and living with disability or life-limiting illness affects different people differently across the patch. And obviously we know as well that poverty is a big challenge for our population. So the strategy really is focused on tackling those big issues that I've just talked about at a high level, which is about those deep-seated inequalities, variations in care delivery. We know that happens, and also variation in the outcomes that people receive when they have health and care services across our patch. So the next slide just talks about how we're trying to map the priorities that are going to be in the 10-year strategy with what we already know. So you'll see the Birmingham priorities are there in that purple line in terms of what Health and Wellbeing Board and other groups have said really is important. So hopefully you'll see those being reflected in what I'm going to talk about. So a number of different sections in the strategy that we'll just go through quickly, starting with the vision, which I think is 2 slides on, please. Thank you. So the vision as the partnership is that people of Birmingham and Solihull live longer, healthier and happier lives. And importantly, what we want from that vision is that that's a reality for everybody, no matter where you live, no matter who you are, that living a healthy, happier life isn't just a privilege for those who've got social or economic advantage. And that's across the whole of the life course, from birth right the way through to the end of life, and that the ways that we're providing services for people are done in culturally safe and appropriate ways that give them dignity and choice. We want to make sure that those who are disadvantaged or disabled by society are protected or safeguarded, and are enabled to achieve their full potential. And that we'll do this by working in a more integrated way, a more connected way across the system. One of the things we hear time and time again from service users and families is about having to tell their story multiple times, organisations and agencies not talking to each other, not sharing appropriate information. So that's something that we really want to address as part of this. And actually, we want to make sure that we're using the very best evidence-based practice in the way that we're delivering health and care locally as well. And actually, where we don't necessarily know what's the best interventions, that we're using research, working with our universities and other organisations to actually develop what will work for our populations, by working with our communities as well to develop some of those interventions. And then finally, as a system, that actually we're thinking about our role in improving the quality of life through our wider role as major employers locally, and also what's called anchor institutions. So, we have lots of buildings across the NHS and local authorities. How are we using those to the benefit of our population? For example, and also thinking about our role on environmental issues as well. So the next next page just starts to go into the objectives in a little bit more detail. So you'll see that there are 6 objectives here, and I'll start with the first one, which is around reducing inequalities. And actually, these objectives, really, there's a recognition that we've all got to do things differently, whether you're a citizen or a service user or you work in the system. Actually, we're all going to have to change the way that we do things currently if we're actually going to make a difference to some of the things that I've just been talking about. So when we're reducing inequalities, that's about making sure that we're all acting intentionally to reduce those inequalities across the patch, thinking about how do we close some of those unacceptable gaps in care, the variations that are not evidence-based, and actually how do we make sure that everybody gets the best possible outcomes that they can achieve. Delivering integration, the second objective, again, is about how do we work better together, how do we share data and information, how do we kind of put the people who are using services really at the centre of what we're doing and involve them much more in decisions about their health and well-being and their care. The third objective is about protecting people from harm, and that's about being a system that is ready if there are emergencies. Hopefully we'll never go through anything like what we've gone through the last few years, but that we're prepared and that we can respond quickly when things do go wrong, and that we are safeguarding people appropriately. The next objective is around being there across the whole of life. So yes, it's essential that every child growing up in Birmingham and Solihull has the best start of life, but also that we're there for everybody as they grow, they age and eventually die. And the aim really is to make sure that people's health doesn't become a barrier to them doing whatever they want to do and fulfilling their potential. One of the biggest challenges we've got at the moment, as I'm sure you're well aware, is actually about workforce and staffing and having enough people who are able to do the roles that we need. So actually being a great employer across the health and care system is a really important objective. Making sure that our workforce reflects our local population, that we're using local talent, that we're growing local talent, and that we're keeping people working and having great careers in Birmingham and Solihull, and enabling people to kind of bring their whole selves to work, however they identify that they feel included in our organisations. And then the final objective is around that contribution to the wider determinants of health. We know that healthcare actually is only 20% of actually letting somebody live a healthy, happy life. And actually it is about the environment, it's about employment, it's about education. So thinking about our role in the system to address some of those wider determinants. And the next part of the strategy then moves on to how do we want to work together. So you can see there's a set of principles. This is about it being owned by everybody in the system, whether you live in Birmingham or Solihull, you receive care, because we know people come from outside the area to receive health and care within Birmingham and Solihull, or you work in the system. Actually, this is about everybody seeing that they've got a role to play if we're going to make the changes that we need to make over the next 10 years. We want this to be place-led, so decisions are made at the right level, that citizens are involved in being able to make some of those decisions and thinking about what needs to be decided at a system level, at a place level, or locality or neighbourhood. And then the third block here is about thinking, how do we wrap health and care through all of the policies that we're doing, and thinking about prevention in particular to keep people or enable people to be able to live well within Birmingham and Solihull. And then the final block's about being values driven, so really embedding equality, diversity, inclusion in the way that we are providing health and care and commissioning health and care, and thinking about our how we add social value as well as major purchasers in the local area. And then the next slide, ways of working, is really about saying that we can't keep doing the same things and expecting to get different outcomes. So we are going to have to work differently, and we want to develop new ways of working, making sure that decisions are made at the level that's most appropriate, thinking about working in a much more joined up and integrated way, and thinking about how we involve local communities more in the decisions that we're making, and empowering them to be able to live well, and actually to challenge us and contribute on the things that are going to make the difference. And then finally, given the universities that we've got locally and the kind of innovation centres that we're using innovation and evidence and research to be thinking about how can we make the changes that we need to make. So what we're aiming for, we start to set out on the next slide, which is kind of 5 big changes that we think will lead to the results that we want for our local population, and our local populations have said that they want. So first of all, that health and social care is fully integrated. I know we've been talking about this for a while, but it really is key so that we don't have those gaps in care between services and people don't have to keep telling their story over and over. But actually the focus is on helping people to live well first. So we're thinking about how do we embed prevention and reduce the impact of disease and in health on people's lives. Thirdly, that we've got a really diverse and successful workforce that can feel able to provide high quality health and care with really great career opportunities. And then the fourth block is thinking about how do we make the most of every single pound that we are given to provide the very best care that we can by using evidence-based practice and working with our institutions, our innovation centres and our universities to think about how do we start to push the boundaries and make some of the changes we want to make. And thinking about those wider determinants of health and reducing inequalities in that kind of fifth block there. If we do that, actually the aim would be to make sure our services are more accessible, more efficient, both for the people who need to access them and also the professionals working in those services as well, that fewer people develop preventable disease or die from causes that are potentially preventable, and that actually our health and care economy is really stable and flourishing and is able to support great careers with a really diverse local workforce. The next section then starts to set out a little bit about how are we going to know that we're making a difference. So what are the things we'll be tracking over the next 10 years so that we can see that we're making the changes that we need to make. And there's 2 different sets of metrics here. There's some that we think might take as long as 10 years to start to see some changes, and there's some that we think hopefully we'll start to see the changes a little bit quicker. That's not to say that we won't see changes in life expectancy sooner than that. It's just that it's so incremental that to see a big difference is going to take a while to bed that in. So those 10-year metrics really are focusing on life expectancy, disability-free life expectancy, and starting to tackle some of the deep-seated inequalities that we know we've got across our geography and between different communities. And then the next few pages then start to set out some other health inequalities that we think we'll start to see some improvements on a bit more quickly. And you'll see some of these are quite specific. We've tried to think about different communities, different inclusion groups. So some of these relate to specific ethnic communities, some of these relate to specific communities by identity. So you can see some information in there around what we want to do around supporting women who are pregnant, mental health support for people, people from certain ethnic groups who experience higher levels, higher prevalence of diseases like diabetes. Where you can see the gold stars next to some of these, that's where they link directly to the health inequality strategy that the Integrated Care Board has just approved. So I'm not going to go through these in detail, but hopefully you can see, that we're tackling some of the major diseases that at the beginning we said are a big challenge for our population, in both across physical and mental health, and some of the things that we know have been a challenge for our local population. Some of them are broader, so you'll see we're also going to be looking at things like where are children at in terms of development by the end of reception, and tackling things like fuel poverty, and what are we doing around young people getting into education, employment and training. So hopefully quite a broad set of metrics really that we're looking to shift over the next 10 years. So the final bit really is then to talk about how are we engaging on the 10-year strategy, because we're building on what we already know rather than a blank sheet of paper. Actually, what we're not doing is consulting. What we're trying to do through the engagement work is actually connect people to the strategy, to check that the things that we're proposing to put in the strategy are relevant to people. They can see that they resonate with the things that they experience and the things that they've been telling the system, the health and care system, and also people like yourselves about the challenges that they have in living healthy, happy and long and fulfilling lives. So what we want to do is to kind of get that connection so that everybody sees, whether you're a citizen living in the patch, whether you're accessing care, whether you're a community group or a voluntary faith social enterprise or a statutory organisation like the NHS or an independent sector provider, that we've all got a role to play in making sure that we make the changes that we want, and that this strategy people feel resonates with them in terms of what's really going to make the difference. We also want to, just moving on to the next slide, we also just want to test that there aren't any gaps, because there might be, and obviously the last couple of years things have changed in huge ways across society. We want to build that ownership, and we also want to identify where there might be opportunities for action that we can start to make some changes on. So in terms of who we're engaging with, which is on the next slide, again, we're trying to give as many opportunities as we can for anyone who lives, works or receives care in Birmingham and Solihull, the opportunity to help shape the strategy. So whether that's citizens, people who are using services currently or their families, the integrated care system, partners and other organisations, health and care, like independent sector, like we've talked about the police, we've talked about fire, a kind of criminal justice system as well, so that they can help to shape that strategy, and thinking quite widely about who has an impact on health and care, and how do we make sure that this resonates with them as well. So the next couple of slides then go into a little bit more detail, which I'm not going to go through in any detail really, about the approach that we're taking to the engagement strategy. On the Integrated Care System website, talked about the videos at the beginning. They're available there in different community languages. There's also links to a couple of surveys that people can complete as well. Two slightly different surveys, one aimed at kind of citizens or service users, and then one aimed at people who working in the system currently at the moment. We are asking some questions in the presentation and on the front sheet about the role of the health and social care overview and scrutiny in terms of these objectives. What more we can do to help make the strategy real for people, so that everybody, we can help everyone to see that we've all got a role to play in making this happen. So to ask you, what are you going to need to see that to believe that we're actually making a difference, that we're focused on the right things and we're seeing the changes that we need to make? We know 10 years is a long time. It's quite hard to keep the faith for 10 years that we're heading in the right direction. So this is our opportunity to really test that. And then the other thing really would be you'll have your own networks and connections. If you could help us to promote the kind of the videos and the surveys, that would be much appreciated so that we can try and hear from as many people as possible. So Councillor, happy to have any clarification questions that people might have. And then if we're able to get into a discussion around the questions that we've posed, that would be much appreciated. Thank you.
Thank you for that presentation. That was really useful. It was really kind of you to present some questions for us to actually consider, but I'm sure members may have some questions of their own. So it's open to members to ask questions. Councillor Pocock.
Thanks. I think you've asked for clarifications and then broader discussion. So just for clarifications, subsidiarity, great principle, but I'm not sure your definition of it is a definition of subsidiarity. Things should be done and decisions made at a level that is most relevant, efficient and effective. For centralisers, that means we make decisions centrally. That's a justification for centralisation. So I think it needs to be, I mean, if you mean what you say, local first. Local first. Where possible, decisions are made as close to people, as close to communities, as close to neighbourhoods as possible. I mean, that's a way of defining subsidiarity. The wording you have makes me feel slightly nervous that it's a paper word masking a continuation of centralised control. So I think that would be helpful if you can perhaps flesh out on that a bit. Secondly, wider determinants. Obviously, the approach to wider determinants is very broad, very cross-cutting, a public health approach. We're talking obviously access to leisure, sport, recreation, food, housing. We all know what the wider determinants are. You've got a limited system here in one sense. I think it would be helpful to spell out that your role is a contributory role towards the wider determinants. And I think it doesn't quite read that way in that I think the implication is there's a need for a much stronger connection between the ICS and all the other activities that go together to make what we used to call it a marmot city, you know, the principle of basically adopting the public health approach to tackling inequalities through all the means by which public health status can be influenced. So I think that could do with a bit more clarity and wider recognition of the public health role. And the third question was to do with the role of, well, let's call it accountability. The job of scrutiny is to hold the system to account. It's not clear from here. I'm not sure whether it's intended to be part of your presentation, but obviously our role as a committee is to establish where we hold the system to account, where we bring pressure to bear on decisions at whatever level they're made. We've clearly got an opportunity at the joint HOSC with Birmingham and Solihull to examine what is done, for example, at the ICB board level. There's a set of consequent questions about how the role of place and then locality within the place, let alone neighbourhood, flows through. This committee is a citywide committee. It could deal legitimately with the place level for Birmingham, but it leaves open. We don't have a devolved structure in the city below the level of the city. We don't have districts anymore. We don't even have ward committees with any decision-making power. But the question, therefore, is left unanswered as to how the scrutiny function of local government in law is carried out at a level below the level of the place. It's an unanswered question. I haven't got an answer either, but I think the question needs to be asked and time put into providing an answer. Thank you, Chair.
Before you actually respond, we've actually got Sue Longdon on Teams. Is there any questions or comments you want to make, Sue, before your colleagues answer the questions that Councillor Pocock raised?
Hello there. Sorry, and apologies for being on Teams. I was unable to travel today. So in support of the presentation and just thinking about the points that were raised about public health, I know that Dr. Justin Varney has done an enormous amount of work on the JSNA and the community profiles and the insight to inform this strategy. And I think what's refreshing from a public health perspective is to see in a 10-year strategy metrics that are set out for a shorter time scale and an explicit reference to prevention in pathways. I know that this is an enormous priority of NHS England anyway, and whether that's stop smoking services in maternity, whether that's brief intervention in pre-diabetes. But I think that discipline of having prevention built into every pathway at ICS level is something that will benefit the population. And I think that as somebody relatively new to the area, the selection of the metrics feels very appropriate to understanding that direction of travel in a 10-year strategy. I think I'll leave it there unless there's any questions.
Thank you. Before you respond to Councillor Pocock's question, I got a sort of linked one. When you look at the fact we've got the ICB and associated ICP, a Birmingham-based partnership, a health and wellbeing ward, at least one private collective. There's a huge number of moving parts in the equation in terms of how you see them all linking in together and what role you see scrutiny as actually having in it. Because in my experience, the more parts you have in the process, the more complicated it is to get an effective resolution.
Do you want me to start with Councillor Pocock, Chair? And I'll try and Suzanne, you come in and kick me if I'm saying the wrong thing. So in terms of subsidiarity, I think for too long the NHS has not been humble enough. There's a great book in November 2020 that was published by Dame Sally Davis. It's called Whose Health Is It Anyway? She used to be Chief Medical Officer for England, and she reflected on the fact that health systems are all too often not exporting good health into communities. They're importing poor health into, our institutions, whether it's University Hospitals Birmingham, whether it's Birmingham Solihull Mental Health Trust. So when we designed the place structure, this is about subsidiarity. My intent, and I talked to Deborah about this as Chief Executive, I talked to Councillor Khan about this, was always to make sure local government led that. And that isn't something that we lead. That isn't something that my officers lead. So the chair there is Professor Graham Betts. He sets the agenda. I delegate and will increasingly delegate more responsibilities down to those place committees as they develop. Now, below that place, you are right. Where we really want to get into is, what are they doing in Bordesley Green at the Iridium practice there? One of the most challenged areas in the city. And how are we bringing health and care together? How are we making sure that the social prescribing service there is linked into everything that we've got to offer in terms of community assets? So that subsidiarity, my intent has always been to make sure that we delegate down. And I think if you talk to your officers, whether it was Richard Brooks talking about the Birmingham City Observatory, which is launched tonight, and how we link into that as health, because I think if you go onto the website there, the only health element on it is the JSNA. There's nothing about a range of the statistics that we've got in the NHS, I think, which would be useful there, or whether it's about how we work much closer together as exec teams. We need to be much more open to local government than we have in the past and be humbler and say, right, 80% of the reason why people are treated in the NHS has got nothing to do with the NHS. It's got to do with poverty, it's got to do with housing, it's got to do with education, and we need to be much stronger around that. So that subsidiarity, I've tried to put in that the place committees have the ability, driven by local government, to actually drive investment. And to do that, we've put £28 million in this year in a Fairer Futures Fund, which is the majority of which actually go to Birmingham and some to Solihull. And that's not for me to determine where that goes, that's for the place committee. So that's subsidiarity we are trying to do, but this is like turning around a tanker. The NHS is a big bureaucratic organisation, but my success as chief exec is to get closer to local government and have a true health and care system. And I do recognise, Chair, that it is complex. Some of these were the changes in legislation. I think we have to look at how we make them work. What works best for the Health Overview and Scrutiny Committee here and Solihull, and what is the relationship between that and the Health Overview and Scrutiny Committee and the ICP. At the moment, we have looked to try and distinguish what each one of those does. There will be some sort of crossovers there. I know that what you just talked about earlier about mental health services is something that I'm the accountable officer for the NHS in Birmingham and Solihull. I'm held to account for the number of children and young people held outside Birmingham and to meet our trajectory, and we're not doing it at the moment. So, I'm held to account for that nationally by the NHS to Amanda Pritchard, the Chief Executive of the NHS. So that's the subsidiarity area. Suzanne works in our community trust and is a director there, and you're working on some of those things that I've talked about, Place, aren't you?
Yeah, and it's interesting actually because we've been doing quite a lot of work in West Birmingham, because West Birmingham has just moved over from the kind of Black Country from an NHS perspective, and actually what we're doing at a kind of a locality level there is really quite interesting and shows you the benefits of working at that level, because you can get people around the table and have those really rich conversations. So I think as part of what the Birmingham Place Committee is going to do, working out what the purpose of those localities are and in time what obligations they might have is going to be really important. But I think you raised an interesting question about how do you get the scrutiny going right the way through the system as well if decisions are made. So I think that's something to take away and reflect on. Thank you.
I should say that I do think that local government scrutiny, this committee in particular, is absolutely crucial to hold us to account. I think there's been a democratic deficit for a long time in health, and therefore I think we do need to make sure that we are held to account. This is I'm responsible for £3.8 billion of taxpayers' money that comes into Birmingham, so we need to make sure we.
So kind of following on a bit from the subsidiarity question, what I'm still not clear on is if this is subsidiarity for the kind of constituent parts of the NHS or the service providers, i.e. a certain practice or a certain service in a certain area is allowed to get on with it in that local area, and whether that's what we mean by subsidiarity, or is it actually local people and local representatives having influence and, dare I say, some power over what happens in that service in that local area. And those are two very different things. Because one is basically just letting the practice get on with it and effectively no accountability, one could argue. The other is possibly for the first time in a while, councillors and MPs and citizens having a direct influence over what the service provision is in their locality. So that, to me, still feels like it needs kind of clarifying exactly what is meant there, and not only clarifying, but when this is developed, kind of, I hope it's obviously the version that allows citizens and councillors and MPs and their representatives to have a real say in what the service provision is, that it's set up in a way which does that. So that, I think that gives them clarifying, and I think and kind of coupled with that, but there's no good having a structure on a local level. Let's say there's a locality committee, for example, of the councillors in that patch, because a locality a neighbourhood will be bigger than the Birmingham City Council wards, so it would include several Birmingham wards. There would therefore be several councillors, at least 3, possibly 5, depending on exactly how you structured it. But there's no point that existing if there isn't actually a resource delegated to that level which can be decided. So if it's just a talking shop at that level, it's kind of not pointless, but it's kind of the need is reducing a bit. So I think, as well as getting the structure right and make sure the right people are around the table, and it is about local representatives and people having an input, it also needs the resources linked into that to be able to actually have an impact and actually have a desired service provision. And my other kind of separate question was around fuel poverty, and you mentioned it, and it's something which is a big issue in my ward, so I have a personal interest in it. But I suppose, what do you see as your role in tackling that? And because it is a real issue and a real major determinant of people's health. But yeah, and I'm interested to hear what you see as your role. And my final point, Chair, if I may, I think it'd be good if we could have, based on what David's just said, on that's a slightly separate point. At some point, David speaking about this, some of the just about the kind of mental health inquiry that we're doing, based on what you said today as well. But anyway, thank you, Chair.
Thank you.
We'll fill those between us. If I could talk about that engagement piece, and I think Councillor Pritchard, you pose a really good challenge to us. Now, our intent is to open the democratic accountability and influence engagement at a local level. Well, I've only been in post since July, and we've only been set up since July. But the reason I asked Graham, that was initially Deborah, but she delegated to Graham to lead the place board, was to make sure that below the place board, we get a structure that meets best the requirements of our key partner in Birmingham, which is the City Council. And I want it to work for the City Council and for the citizens of Birmingham. So you do have an opportunity to influence that, and I guess we can actually sort of reflect your comments in the strategy in terms of, you might want to hold me to account and say, well, what does engagement actually mean? Now, there is one aspect to that I'd have to say there are some certain national standards which the government have said you will have to deliver on those. So whether that is access to primary care services, there's a very specific requirement now of me around improving access to primary care services, and that can't vary whether it's in Handsworth or in Stechford. That has to be that same outcome. Similarly, waiting lists, they have to come down and shouldn't be variable wherever. Now, we are looking at what we could delegate down to place and neighbourhoods that make sense. Now, that may well be some of our community services and the budgets around community services, but also some of our joint budgets that we've got with Birmingham City Council. You probably don't know, but 10 to 12% of our budget funds social care in Birmingham, and that will go up with the announcement in the fiscal statement last week. So should we be better at looking at what's going into the Better Care Fund and actually seeing the outputs of that? And that's the requirement that I've got on myself as accountable officer to do that, and I want to do that with local government colleagues. So I do think we've got some way to go. In that, rather than just delegate it to providers, getting true engagement. And we've got on our board, we have got Anu Kana, who is an expert in engagement, and I'm asking her to help and support us around that. But I think you need to hold us to account. If there's not a change in a year's time, you need to hold us to account on that. Do you want to deal with the fuel poverty?
Yeah, so in terms of the fuel poverty and things like the Healthy Start vouchers that are in here as well, I mean, we've got 80,000 staff working in the NHS. Most of those are kind of frontline clinical people. And years ago, Sue and colleagues in public health would have been talking about making every contact counts. When a health visitor is meeting with a family, are they saying these, things like these benefits are available to you. Here's the information that you can get about those, making sure that people are accessing every source of help that's available to them. From a Birmingham Community Trust perspective, again, our health visitors, our district nurses, are they well connected to know what the local community infrastructure is? So they can connect somebody, not just with benefits, advice and information, but with groups that are available to provide support. So making it much more connected. So that's where we see, we've got more to do. And actually, it's because the information is out there. It's just sometimes health professionals don't know what available information is there and how do they signpost the people that they're supporting with their health and care to that wider support that's available. So that's the kind of thing that we want to be doing around some of those things.
Thank you. Before we go on to elsewhere, Sue, do you want to make a comment to the last question?
I think the only thing I'd add to that last question about fuel poverty is that there are operational and strategic responses to fuel poverty and the wider cost of living emergency. So absolutely Suzanne's point about making every contact count and ensuring that at every opportunity that there's a discussion about people having access to all of the benefits and support that they can have. But there's also the ICB involvement in the cost of living city partnership and that emergency group. So we make sure that all of the responses, all of the plans are aligned and that we get the added value of of working collectively to the same ends. So I think that's the only thing I'd add there.
Okay, thank you for that. Councillor Tilsley.
Thank you. If you'll forgive me, I'll just humour me for a few minutes as I have a little ramble. Because one of the issues that you raised was workforce and planning. And we know, we're told every day that there's 250,000 shortage in the integrated care system, NHS and care. And that is creating enormous problems for the health delivery. If you can't get patients out into the community, don't be surprised that you've got queues of ambulances outside because there's nowhere for them to go. And it's a real issue. And I think it's one of the byproducts, unfortunately, of Brexit, where a lot of the care staff said, thank you very much, we're off. And as a consequence of that, I know that the NHS in general is trying to recruit internationally. And that is one of my pet concerns. So I raise it as an issue. The other issue that I'd like to raise is you've identified a number of priorities, particularly on pages 31 and 32, cardiovascular, diabetes, cancer mortality. The one thing that you haven't identified is the elephant that's in the room. And it's only come in the last couple of years, and that's long COVID. You made a reference to it en passant, but 3% of the population now are suffering with long COVID. And that's excluding them from the workforce. Now, what locally is being done to support people who are suffering from it? And there's a reason for this question, because unfortunately, my daughter, who is coming up to 40, has had chronic fatigue for half of her life. Now, I worked out that in Birmingham, there was one person who'd got CFS, chronic fatigue, in every street in Birmingham. Now, because of long COVID, there's another 2 people in every street in Birmingham on average who are suffering with long COVID. And I really don't see that the NHS is really trying to tackle the problem. I'm a late night bird, forgive me. There was a very good, and I channel hop on the television, but there was a very good debate in the Lords last Friday on long COVID. And a number of contributors were linking long COVID with chronic fatigue and CFS. Now, I know that locally, the ROH were given the lead on long COVID. Now, they're brilliant. They've done both my knees, but I didn't see them in the frame for tackling long COVID. So I really want to inquire what is being done as far as help and support within the Birmingham Solihull integrated care system for tackling that issue, because a lot of people now are becoming completely excluded from society. And I know this to my own personal cost because of my own experience. So I'd be grateful. As far as Councillor Pritchard's comment about engagement. I'm a sad old sod, forgive me. I was involved in the community health councils 40 years ago. Primary care trusts. I was a non-exec, and I'd got responsibility for 2 primary care trusts that were based upon constituencies. So I was chasing around doing that. But it really is to try and get the engagement at the local level. Mm-hmm. And I think that is of paramount importance. As I said when I started, forgive me, I'm having a ramble.
Thank you, Councillor Tilsley. And just to say on the engagement piece, it's something that I'm held accountable for by the Chief Executive of the NHS and engaging both MPs and local members. So it's something that we do need to make sure that we get right. And I need to think through how we're best doing that. Just in terms of the workforce, look, we have got a workforce crisis in the NHS. I'm not going to duck that one. It's going to be exacerbated from December, I would guess, with the industrial action that we are facing, if indeed we do get industrial action. But we are well aware of that, and it's interesting that the Chief Executive of the NHS is saying that we almost need we need to step back and think about how we do workforce planning in the future, because we do rely to an extent, less so than some of the systems, but we still rely to an extent and bringing sort of workers across, staff across from internationally. We've got some great institutions in Birmingham, but we're next exporter of healthcare staff from Birmingham and Solihull, which isn't a good place to be. We need to attract people in here. In terms of long COVID, it's a really good question. And, you know, I've not heard the statistics that you've said. Joe Williams, who is the chief exec of the Royal Orthopaedic Hospital, what I asked each of the chief execs to do when I came into post is to lead on a certain area. So whilst she's the chief exec of the Royal Orthopaedic Hospital, out with that, I'd asked her to support and develop the long COVID services for the whole of Birmingham. So we shouldn't link the two together too much. You know, she's an experienced leader and manager. Now, we do have long COVID services, and it might be something that off the top of my head, I can't tell you how many, where they are, but it might be something we can send a note in afterwards that you can scrutinise, you can look at. I know we do provide them. I know we provide them for staff, because I've got some of my staff going through them at the moment. You know, because this disease has impacted on lots of people in the way you've described. So we have got a response, but whether it's commensurate with what we're facing, I think your question is a good one. It's one we probably need to consider in terms of the strategy.
Thank you. Of course, all the empirical evidence is that it ain't going away.
And we've still got patients with COVID in our hospitals now. We haven't got COVID at the same level we had 2 years ago. We still have COVID, and our vaccination rates are poor. Only 1 in 4 frontline healthcare staff have had their COVID boosters. So because of the way that, you know, the focus on why they had to have them last time, they're almost forced to have them.
Thank you, Sue. Do you want to make any comment on that question?
I think the only thing that I would add around COVID, just building on David's last point about the COVID vaccination, the uptake is poor both in health and care professionals, but in vulnerable populations. And I do know that Justin has been doing an awful lot of, he did a few media interviews on BBC Local Radio last week. It is very challenging. And as David said, I think the position initially as staff being required to be vaccinated has created the unintended consequences of that. It's a big hearts and minds piece to get people to be vaccinated now, but it's hugely important.
Okay, thank you for that. We've got 10 minutes left. I've got a question to ask them, and then bring Councillor Hartley in. You made a comment a few moments ago about holding the ICB accountable, and I'm just wondering, do you envisage that being through the individual HOSCs, through the joint HOSC, or do you see that being as through the individual place partnerships, or or a combination of all of those?
So the place partnerships are accountable to the board, to the ICB board. So they are a committee of the ICB board. Now, I would work with the OSCs to say what works best for you. Would you prefer it to be a Birmingham and Solihull one or a joint one? We often find it better coming to the place, i.e. Birmingham and Solihull, rather than the joint one, if I'm absolutely honest. Because you can have more focused discussion about that place. And for me, personal perspective, but I know my executive team feel the same about that as well.
I think it would be my personal choice that it was done. You came to Birmingham and to Solihull as individual ones. But it was just a question I wanted to ask. Then the second point was in terms of the ICB makeup. I wondered, did you have there's a lot of voluntary carers, family members who look after people at home. Do you have a representative from voluntary carers on the ICB? And what's the position in terms of West Midlands Ambulance with that?
So we do have BVSC on the partnership. Yes, we do. And Healthwatch. So they're both on the partnership, and Healthwatch also come to our board. We are more constrained on the board. Legislation didn't constrain the board, so it's much more like a trust board, a provider trust board in the NHS, albeit it does have partner members from local government, from GPs and from providers. But local government are on our board. Professor Graham Betts comes to the ICB board.
Okay. And then in terms of West Midlands Ambulance, are they on the partnership?
So we request, so they are commissioned via the Black Country. So they are on the Black Country partnership. Now, when we talked to Anthony Marsh, we said, well, is that right, given that 50% of your funding comes from Birmingham and Solihull, but they are actually hosted in NHS terms in the Black Country, not in Birmingham and Solihull. But we do engage with them on a regular basis, and indeed, I'm arranging for your leader and for Councillor Khan to go out to Brierley Hill Control Centre to have a look what they're doing and see what they're doing to meet with Anthony Marsh, because I do think it is important, given the amount of money the NHS in Birmingham and Solihull spends with them, that our local elected representatives can see what they're doing and the great job they're doing.
Yes, it's back to the local level of this process. As we've moved through the pandemic and after 2 staff changes, we're now engaging with our neighbourhood network coordinator, which is around adult care, health and so on. And we're able to have a proper ward forum session with her. I just wondered how far the consultation, involvement and feedback elements are going to involve somebody like that at that level. Obviously, she's employed via the Birmingham settlement, I believe, but it's to deliver this service, which certainly council and others involved feel is absolutely necessary at a constituency level. So how's that going to pan out?
Yes, so we've actually done quite a lot of work with colleagues in Birmingham City Council about using the networks that to kind of promote this and push this out. So Justin Varney and myself have done 2 kind of open access online events in the last couple of weeks that are open to anybody who wants to attend, and we've pushed that out through the council's network. We've actually commissioned BVSC, who are working with 18 community groups in small grants to run engagement sessions as well. So I don't know if Birmingham Settlement is one of those groups that's picked that up. But BVSC are also pushing out information about the strategy to all of the different networks and connections that they've got as well. So either through the council route or through BVSC, hopefully those neighbourhood network scheme providers would be aware of this and have the opportunity to contribute. But equally, we're really happy if after today people again use their own networks to share this information more broadly, and people have the opportunity to fill in the online survey and let us know what they think as well.
I'll speak for other wards and constituencies, but I think this needs to be emphasised and brought to people's attention. It's only because I know the person who's the latest to take on the job of coordinator, really, that has meant that I've tuned in onto what our work's going to be.
We're slightly ahead of time. We've got time for either 2 quick questions or 1 longer question. So, Councillor Pritchard to get his hand up first. So,
on the ambulance, could they not be in both ICPs, ICPs, both Blackwell and Birmingham? Would that not make sense if that funding is coming from each? So that was my first quick question. My second one is going back to this issue of localities and neighbourhoods. Would the government ever have control or a say in the procurement of services in terms of that money and kind of saying we want to spend this money on this service? But it get to that level, or are we talking much more kind of less kind of controlling, more strategic than that?
I'll deal with the ambulance one first. So the ambulance one, as much as I would like to ask Anthony Marsh to come to both, he's a busy guy, and if he comes to us, he would also then have to go to Coventry, he would then have to go to Worcester, he would then have to go to Shropshire, and he would then have to go to Staffordshire. I mean, he just can't do that. And it's how we get the balance of engagement with the ambulance service. They have turned round ambulance turnaround times in Birmingham and Solihull in the last 2 months by putting paramedics at the front doors of our A&Es at UHB, at the Queen Elizabeth, at Heartlands and at Good Hope. And that is testament to the joint working between West Midlands Ambulance Service and the local NHS. They've been exceptional. But we do engage with them, Councillor Pritchard. I wouldn't want you to think because they're not on the board, they don't engage. They do very much so. And in terms of the decisions, ideally, I would like to, and it's an ideal at the moment, we're only a few months into the ICB and the ICS, is make sure that some decisions are taken at a local level that makes most sense at that local level. If I take you to the Iridium practice, again in Bawdsley Green, they have resources there. Now, I would love to have them to have the resources that make sure their social prescribing is as good as it can be. And if you Google on the BBC, Birmingham social prescribing, there's a patient story or a citizen story there of art. There's a 53-year-old guy from Birmingham who wanted to be treated at ROH because he wanted shoulder surgery and he got mental health problems. He was out of work. Through social prescribing, so a GP not sending that individual to the ROH or to Birmingham Social Mental Health, he's become a peer support worker, he's got a job, and he's been treated. He's done that through a walking group. So that can best be done locally, not from Wesleyan, the Wesleyan building where we sit at the moment. That has to be done locally. And it's those GPs and those local communities that can best curate those services. It's those type of services that I would see being determined at neighbourhood level, because I think that's what's required.
Comments? Not.
And I would just agree with that. I mean, I think that's really important. I think there's a balance between things that it works better if they're done once for the whole of the city or the whole of the system. And for some services, that's best. For others, it is absolutely about tailoring it to local need at local level and people at a local level working together to decide what's going to work best. And actually, I know from some of the work we've been doing in Ladywood and Perry Barr, the voluntary community faith sector organisations will be very different in one part of the city to another. So in terms of those networks and working together to think about how do we support people living in those areas, it's heartening for me as a provider to hear that that's kind of where the ICB sees things going.
Okay, thank you. Well, we've come to the end of the time slot, so Can I thank members for the questions? It's been really useful. Can I thank you three for the presentation, which I think it's been really valuable through as well. I just wonder, would the committee like them to come back in the early new year, assuming we have space in the work programme?
I think it would be helpful to do that, Chair. And also, I think it would be useful to have a who's on what. But we've actually seen who is represented on what. I thought table, but if we not had it, could we have that too?
So Chair, I can make sure you don't need to wait for that. I'll get one of my team to do that and pass
And
it.
if you can liaise to either through Fiona or Gail to get those arranged.
I'll do it.
It's located to the committee.
Yeah,
Thank
That would be
you.
great.
thank you.
Thank you very much. Need to bring those to the table. We now move on to item 6, which is substance use. We've got the Birmingham's Adult Treatment Services here. We've got a presentation which will be delivered, if I'm correct, by Carl Beast, who's Commissioning Manager for Adults Public Health. Chris Baggett, Service Lead, Partnerships, Insights and Prevention. Victoria Loveridge, Head of Service, CGL. And David Lewis, Director of CGL. Okay, so we've got about 50 minutes for this programme, so if you want to do about 20 minutes presentation, and then we can go in for questions.
Councillor Brown.
Yourselves.
Right, good morning everyone, nice to see everyone in person. And good to meet the new committee members as well. My name is Carl Beans, Commission Manager for Adult Public Health Services with a remit for substance use. I'll be presenting slides 2 to 4 today. So I've got my colleague Chris, Service Lead from Public Health, doing slides 5 to 6. And our CGL colleagues, Vic Loveridge, Head of Services, Birmingham, and David Lewis, Director of Midland Services, and they'll be delivering slides 8 to 15. And in addition to our presentation, you'll also have received additional info from Birmingham City Council and financial information with regards to the contract, as well as some CGL demographics of our service users, their through care guide, and some service user case studies that are really powerful in articulating the powerful impact that the CGL service has made on people's lives. So if we can go on to slide number 2, please. And it might be you need to press again there.
Yes, it'll show it bit by bit.
Yeah, they'll all drop in. Yeah, so the adult substance use service in Birmingham is delivered by Change Grow Live, CGL, who are part of a multi-agency partnership approach across the city. The contract commenced on the 1st of March 2015 and ends on the 31st of March 2024. The procurement process for the period post the 31st of March 2024 has commenced. We have an annual contract value for 2022-23 and 2023-24 of 14.6 million. And the annual contract spend since the contract commencement in March 2015 is detailed in the additional financial information provided. We've also got additional Office for Health Improvement and Disparities, OHID, which was previously Public Health England, grant funding of just over £4.5 million in 2022-23. And again, details of each grant is contained in the supporting information. The key commissioning intentions of the adult substance use contract is to think family, support families during the recovery process, and reduce any associated harms caused to children. A single system with CGL as the lead provider, and then other subcontractors sitting beneath CGL as that lead provider, and a focus on recovery as well, the wider picture around employment, reconnecting with family, etc. Next slide, please, Fiona. Right, so the current position in terms of drug misuse in Birmingham, there are approximately 10,500 people using opiates and or crack. The latest data available is 2016, so it is government estimates, that figure. And we have an average of 82 deaths from drug misuse per annum, 246 for the period 2018 to 20, which equates to 7.8 deaths per 100,000 of the population. The England average is 5, highest is Blackpool with 22.1 and the lowest Enfield, so we're just above the England average. We have 6,388 clients in treatment. The last 4 year figures for 2021 from the National Drug Treatment Monitoring System, so there's always a time lag of approximately 12 months. And that's an increase of approximately 10% compared to the year before, 2019-20. Those people that we do have in treatment and those that are new coming into the treatment system tend to have multiple complexities, i.e. mental health and then other health issues due to their drug misuse. Positive news is that numbers in treatment are increasing. That yearly figure of 6,388 people is the highest number since 2012-13, so nearly 10 years. And there is a minimal waiting time in order to access services, with more than 99.5% of clients accessing the service within 3 weeks, and more likely closer to 2 weeks rather than 3. Next slide, please, Fiona. So in terms of the current position with alcohol misuse, nearly 13,500 people in the city are alcohol dependent. That's 1.58 people per 1,000 population. And again, the data is government estimates, and that was from mid-2018. We have an average of 128 alcohol-specific deaths per year, 384 for the 2 year period, 17 to 19. Alcohol clients, we've got nearly 1,500 clients in treatment. That was 2021, which is the latest 4 year data available. An increase of approximately 29% compared to 19-20. So a similar picture to drug misuse. Numbers in treatment are increasing, which is positive. There's a heavy drinking profile of those actually within treatment. In Birmingham, alcohol clients are at the high end of the daily stroke weekly alcohol unit consumption. So a very high risk stroke dependent clientele. Numbers in treatment are increasing. Figure of 1,472 is the highest since 2016-17, which again is a positive. And again, as with substance misuse, there's minimal waiting time to access services, with again, more than 99.5% of clients being accessing the CGL service within 3 weeks. So I'll now hand you over to my colleague Chris for slides 5 and 6.
Thank you very much, and thank you, committee. So I've got a couple of slides here to talk through. First of all, this slide is giving an indication of where most service users for CGL service are supported in the city. This includes all service users for that, so that's any drug type that they're receiving support for, and alcohol. There are additional maps in the supporting information pack that you've also got that provides different maps for different types of drugs and alcohol separately. So you can see the breakdowns. So this gives you an indication of the rates of number of service users in the treatment service per 1,000 of ward population. The darker the colours are those furthest above the average for the city. The lighter colours are those below the average. So here you can see, and I appreciate impossible for you to see the ward names on the screen, but I hope you can see the detail in your packs if you need to. The darker coloured wards there, they're the wards Gravelly Hill and Lascelles, and they are very significantly higher than the Birmingham average of number of service users per 1,000 population, as I explained. Significantly higher than the average are Aston and Birchfield. And then we have a number of wards that are higher than the Birmingham average. We can't say they're significantly higher. There's a lot of statistics work done on this data. So some will be higher than the average, but not necessarily significantly so. And those higher wards are Shard End, Stockland Green, Handsworth, Holyhead, North Edgbaston and Balsall Heath East. The orangey beigey colour, which is across most of the bottom 2/3 of the map, those wards are in line with the city average. And then you've got wards towards the north and northeast of the city where they're below. And you'll see similar patterns in the additional information pack, the other maps that you've got in there for the different drug support clients and the alcohol clients. Sorry, let me just add that on there you can see the purple dots represent the hubs that CGL work from. I should add that there's also a city centre hub, which colleagues will talk about shortly, and that's not on that map at the moment. If you can move on to the next slide, please. And thank you. So we have a draft drug and alcohol strategy for the city, which is called 000. That was drafted around the start of the COVID pandemic, so publication has been delayed. It's called 000 because we have 3 key ambitious outcomes that we're aiming for, all around the zero label. So it's 0 deaths due to drug or alcohol addiction, 0 overdoses due to drug or alcohol addiction, and 0 people living with addiction to drugs or alcohol not receiving the support to manage or overcome their addiction when they need to. They are very clearly very ambitious outcomes, but we're quite clear that the population of the city deserves no less than those ambitions, however difficult they will be to achieve. The government published a new 10-year drugs plan, also called a drug strategy, called From Harm to Hope, in December last year. And that's got 2 key focuses, one around the criminal elements associated with drug and alcohol use, and one around the health elements and health outcomes, primarily treatment and recovery. It's a 10-year plan, and it's also, as part of the crime elements of it, it's also seeking to change demand and look at breaking up networks that exploit people's addictions. As Carl has already explained, our procurement process is underway for the new contract, both for our adult and our young children and young people's service, which is a separate contract. And those new contracts will be in place from the 1st of April 2024. And obviously, as part of that, we are utilising our 000 strategy ambitions as part to feed into our commissioning intentions, and we'll also be ensuring that we're taking on board key elements that the government and Department of Health are requiring to be delivered as part of the National Harm to Hope plan. I'll just hand over to CGL in 1 second. I should just to add, the 000 strategy is going, the final draft of the 000 strategy and all of the supporting information around that. We have a new needs assessment, as well as feedback from the public consultation that we did. That's all going to Health and Wellbeing Board in January and to full Cabinet in February for sign off and publication. And I'll hand over to Vicky.
Thank you, Chris. Hello, everybody. Can I go to the next slide? Thank you. So, Change Grow Live have been providing drug and alcohol support to anyone over the age of 18 in Birmingham since 2015. We deliver the service alongside our partners, Datus, Ticket, Emerging Futures and Intuitive Thinking. And they all provide a real mix of skills and expertise, ranging from mutual aid and peer-led support through to bespoke groups around mental health and employment, to engaging with Black and minority ethnic groups and prison leavers. We know that actually working in partnership is key to providing the best outcomes for our service users. And over the years, we've built our relationships across the city. I believe in the last year, a lot of those partnerships have really strengthened, particularly with mental health services. We know that some of the service users that we work with are at greater risk, and actually the impact of drug and alcohol use has a bigger impact, and actually they require more specialist interventions. So we have a number of specialist teams, which I will talk about a bit more. But here we have our 4 main hubs located across the city. So we're in South, Central, West, East and North. And as was touched on earlier, we opened Lonsdale, the city centre, which I'll talk about a bit more shortly. Can we move on? Actually, before I move on, can I just say that everyone is welcome to come. We're very proud of the work we do in our hubs. So if you ever want to come and speak to staff or service users, then please let us know. You'd be very, very welcome. Okay, so this is just to give it a quick overview because we've already looked at some of the data. So between September last year and August this year, over 7,500 people have accessed structured treatment. So you can see there's been an increase since the year previously that Cole talked about. Our current caseload, actual caseload of people in structured treatment is just under 5,000, and you can see the drug breakdown there. To the right with the pie chart, you can see the split of the caseload across the localities. Okay, next slide. So the first 4 years of the contract, our model was based on having been in the city centre, excuse me, and our locality teams would come in once a week, and the rest of the week they'll be out in communities, seeing people where they needed to be seen. And during that time, we listened to service users and staff, and service users were saying to us, actually, they wanted a more local service that had provided a broader reach of support. And our staff wanted to also be able to connect more regularly with their peers. So in 2019, we moved out into those hubs that we talked about in the first slide. But actually, what we really felt is that we were missing a city presence, particularly for our most vulnerable service users, which are rough sleepers in the city. So in January this year, we very proudly opened Lonsdale, and it's a fabulous space. We have various facilities there, a shower, washing machines, dryers. We provide toiletries and clothes for service users. And it's become the base for the rough sleeper team, our prison leavers team, and our Bouverdale team. During this last year, the rough sleeper team has grown, and it's really embedded itself in the city, developing fantastic partnership working relationships with primary and secondary care, with housing, the rough sleeper initiative, the police and third sector providers. So within Lonsdale itself, we provide clinical interventions. We've got a dedicated nurse and medic for the rough sleeper team. So they will assess people for physical and mental health issues and refer them on to specialists as required. We provide harm reduction there. So that includes bloodborne virus testing and referring on for treatment, needle exchange. We provide naloxone, which reverses the effect of an opiate overdose. The team do a lot of outreach work. So you might see them in the city centre, or out in the communities, and they often do that with partner agencies. So that's about really building trust and encouraging people to come into treatment, but also to encourage them to access support with other providers. We also provide a lot of group work there, and more recently, auricular acupuncture, which really helps with withdrawal symptoms. Go to the next one. So, prison leavers team. We know that for some people leaving prison, it can be very scary and daunting. And actually, following referral to us, if they miss their first appointments, they sometimes don't engage at all, despite our efforts to engage them. So last year, the prison leavers team was launched, and the purpose of the team is to increase the number of people that are coming out of prison, engaging in treatment with us, to break that cycle of offending and to support them to make positive changes in their life. So the team over the last year have building those relationships with the prisons, and in the last year we've had 46 prisons that refer to us, the largest being Birmingham, as you would expect, and then Hull and Foston Hall. And during that time we've seen a 10% increase in people that are engaging following release. So we deliver the service in partnership with Kick It and Emerging Futures. Emerging Futures provide in-reach and through the gate work, so they will go into the prison, meet someone pre-release, assess their needs, talk about what the offer is, and then on the day of release we'll go to the prison and literally bring them to the locality hub. Kick It do something very similar, but they really focus on people from Black and minority ethnic groups. Our current activity in that team is we are growing the team to really complement the work that Emerging Futures and Kick It do, so we can build on the successes so far. And we're also embedding ourselves in the Inside Out Hub at HMP Birmingham, which is a pilot that's underway currently, with multiple services working together to really improve the day of release for prisoners. So next slide, please. So Buvidal is relatively new to drug treatment, and it's an injectable form of buprenorphine. Buprenorphine is an opiate substitute treatment, and it's administered on site at Lonsdale by a nurse, and it's administered once every 4 weeks. And it has great benefits for people. Although the numbers are relatively low, we've got a real mix of people there. So, for example, people who have really struggled to reach stability on more traditional medication like methadone, because they have to go to the pharmacist every day, and actually they really struggle to do that, so they're on and off their prescription. To people who are employed and actually they just want to get on with their recovery and not have to be tied to trips to the pharmacy. What people are reporting is that they're feeling much more clear-headed because of that stability and really want to use their time productively. So we've developed a number of groups, and of those people, we've supported 14 into training and education, which is fabulous. Because it is relatively new, we're contributing to national learning, and Birmingham is seen as having a number of successes, which is fabulous. Next slide, please. Thank you. So I just wanted to touch on formal teams, our specialist teams. So I've got the Women's and Families team. Interventions that focus on with children is really part of our core offer across all our services. It's a fundamental aspect of what we do. But since 2015, we've had a specific team dedicated to the more vulnerable women in our service user group. And since 2018, they've had their own hub. They work in partnership really well with the Children's Trust, with specialist midwives, with the family drug and alcohol courts. And some of the things they do include running healthy pregnancy workshops jointly with the specialist midwives at the hospitals, and also outreach with specialist midwives. We have Intuitive Thinking Skills, who run Enough is Enough programme at the hub, which looks at supporting women to reduce domestic abuse, sorry, empowering women to stop that cycle. I'll move on to the hospitals team. So the hospitals team, we have workers based in the 4 hospitals, and they work to increase awareness of our service. If someone is referred to them who's been admitted to hospital and they're not known to us, they'll go on the ward, assess them, refer them into treatment with us following discharge. They act as a link between the doctors in the hospital and our medics, who will provide advice around managing withdrawal and medication. And crucially, it's that through care from the point of discharge to treatment to ensure that that continues. And equally for people who are known to us, who are admitted, they act as that link between the community and the hospital to ensure there's that continuity of care. I just want to go down to the blue light. So a blue light model was developed by CERN, and it's a model that we're adopting in Birmingham. So we're in the process of establishing that team, and they will be a dedicated team for alcohol users who are frequent attenders of hospital and other blue light services who are otherwise resistant to engaging in treatment. So we're in the process of pulling that team together, almost recruited nearly everybody, and they'll provide specialist interventions and work alongside blue light services. And we've seen that as a really exciting progression for us in Birmingham to engage some of the most poorly people probably in that alcohol cohort. Individual placement and support is a service that we piloted in Birmingham along with 6 other providers across the country, and now it's been rolled out fully as part of the new OID funding. The team, it's quite a small team, but they provide pre and post-employment support to individuals accessing our service who are job ready. And beyond IPS, we have workers that are based in job centres across the city to really build those partnerships and also encourage people and support them into employment. We have, we know that a lot of people, some people have never been employed, have very low self-esteem. So we do lots of work around supporting them to enter into education or training, for example, through Furcroft. And we're currently really building our offer. Intuitive thinking skills, run a programme that we're building that will support individuals to become job ready. So like all social health and care providers, we are facing challenges around recruitment, and we are looking at how, where we advertise our posts. We do have a lot of volunteers in the service and always have, and they are people who may have lived experience and also various professionals, and they bring a wealth of skills and experience, which is amazing that they give us their time. And we've, over the years, have recruited a number of those people, particularly lived experience, into permanent positions. And we also have a recovery motivator role, which is the first steps into employment for people with lived experience. We have a number of student placements, including we offer social work placements. And again, it's a way for us to get people to understand what our service user group experience. They can take that forward into the work that they go into, or hopefully when they graduate, they'd be interested in coming back to work for us. And nationally, we are developing an entry level worker role, which should really support us to drive our recruitment. In the last slide. So we always encourage people to give feedback, whatever that feedback is. And this is taken from Care Opinion. So we ask or suggest to people that they put it on Care Opinion, and it's in the public domain for anyone to see. And some of these quotes are real testament to some of the fantastic work that goes on in our localities across the city. And also, I think Carl talked about the case studies that are in your pack. And if you haven't read them, I hope you do, because they're really very moving and powerful stories. Thank you.
Yeah, that's okay. Thank you very much. It's been appreciated. Members' questions, Councillor Moore.
Thank you, Chair. 3 questions. First of all, going back to the map which obstacle walls with highest levels. There seems to be a very strong correlation between exempt accommodation and HMOs and quite high. So is that the reason why they're high? It's because this is primarily where these substance users who are seeking treatment are living. And what work takes place to work with those providers? Because certainly the impression I'm given is a lot of them don't provide a lot of support. And quite often you'll find these are vulnerable people who may have recovered or are in the process of recovering, but are placed with people who are openly drinking or taking drugs in the same property as they are, which obviously makes it much more difficult to recover.
Yeah.
A lot of that's anecdotal, but certainly I'm concerned about that there are providers not supporting vulnerable people. So what work are you doing with those providers to ensure that these people are being supported? Because quite often, once they go off the rails, they call local communities, they fill our inboxes with complaints, etc. And it's created a real negative impression of HMOs and exempt accommodation as a result. My second question is in relation to street drinking. My ward in Ernton has a significant problem with street drinking taking place. People will literally be there from 9 o'clock in the morning till all hours of the night, sitting in the street, drinking constantly, congregating. A lot of them don't necessarily live in Erdington. They get on the 11 bus and come to the high streets. What work takes place as part of your outreach and engaging with these people who, it's not unique to Erdington, but we have a significant problem. We've had to get a PSPO and all sorts to try and tackle it. And the police are spending significant resources trying to tackle that. Whilst, finding them or throwing them in jail is one solution, tackling the substance misuse is the other angle to this. So what work in terms of your outreach is done to tackle street drinking? Certainly I'd like to know my ward, but in other places in the city as well. And again, on the outreach, there's quite often a lot of homeless people / begging taking place, particularly in the city centre, but in other areas as well. And the ring road is particularly notorious. No matter whatever junction you get to, there's always someone stood there with a cup asking for money. And I've seen people who've handed them food and they openly discard it because, quite frankly, they're not interested in food. Some of these people, they want the money to engage in drugs.
Yeah.
What outreach are you doing to tackle those people? Because certainly my experience is it's the same people day in, day out on the streets asking for money. So I appreciate you doing a lot of good work with the outreach, but are you hitting the people where it's most visible being causing a problem? Because, don't dispute all the work you've been doing, but certainly my impression going around there, it's not reaching the areas that I see.
Okay. The last question around begging. So our homeless team have targeted people at traffic lights and did a whole piece of work going out there jointly with other providers. Actually, a significant number of those people are accommodated and not rough sleepers, and are already engaged in treatment. So it's a difficult one to answer because there's only, I guess, so much we can do to try and engage and talk about change of behaviour with people, which we always do. And then it becomes a bit of what's the word? Social order situation. So there was the suggestion that we go out with the police, for example, but I think that would be the wrong thing for us to do because we're not enforcement agency. We're a support agency, and what we don't want is for people to suddenly disappear and disengage totally or not engage at all. So yes, we have targets, and we do target those individuals, and it is all about building trust and supporting them to try and get into treatment if they're not in treatment. But equally, if people are going to give people money, then it's a difficult one for us, isn't it? Because some people can earn an awful lot of money at traffic lights.
And I also think the blue light approach in the city will also have an impact on that because supporting and train our partner or organisations with the skills and expertise with the treatment population. So when they have the opportunity to engage, that'll be more skill to offer that support and then get engagement into our service.
Thanks, David. I think just one bit to add from me on that, just to reiterate what Vicky said about the work, especially round by the Bristol roadies. I think it's a fine line when it becomes an enforcement order for people as well, then, because as Vicky said, we don't want to be seen as going out with the police and being part of that enforcement approach, because it is really difficult to engage with some of these people for numerous reasons. And I think touching on, going back to your second point, Councillor Moore, about the street drinking in Erdington, I know a lot of work's gone on in Erdington as well in terms of CGL going out in terms of outreach. And I think it's that borderline, where does it become an enforcement issue for people to be arrested because of it? And when is it an issue for CGL? And I'm confident that CGL and their outreach teams now that are citywide, because of the funding we've got, I think it's really positive, and you continue to work in partnership with the police, don't you, as well?
Yeah,
and
absolutely.
other agencies. So it's not just the police, but other.
And there has been recent walkthroughs on the high street, because we know where people are. You're absolutely right, and it has to be about building those relationships, but that can take a bit of time. You know, I think building trust with people to encourage them into treatment is the biggest hurdle, really. But equally, you know, we are getting more money coming into the system, which is fabulous, because we've had people on, you know, significantly high caseloads over the years. So to ask them then to spend periods of time doing outreach work, it's been a bit of a fine balance. So we're really excited that actually with more staff coming on board, we can do far more of that outreach, building relationships, encouraging them into treatment with us.
Thanks, Vic. And I think coming back to your first point, Councillor Moore, around the numbers of people in treatment and the links to HMOs, I think that's definitely a factor, as well as other indications of deprivation. And Chris, you can probably come in on that from our side, and Vic as well, because I know CGL do training for HMOs, don't you, Vic? And
do you want to cover that?
Yeah. We deliver drug awareness training. We've trained people. I've mentioned about naloxone earlier, which reverses the effects of an opiate overdose, and provided that to housing providers. So we'll do anything to support individuals and accept referrals from them. Often we've had GP surgeries, because we're in shared care. We've got a number of surgeries across the city that we sit in, and they have talked to us about HMOs nearby, where they're seeing people coming in for various health reasons. And drug and alcohol use. So we're connecting with people there also.
And just in terms of looking at the association between those wards in the city with a high density of CGL service users and the density of HMOs and exempt accommodation, we haven't looked at the association between the two. We can do if we can get some more refined data from CGL to show what type of accommodation their service users are in. We can certainly run that analysis and look to see what the association is and report back if that will be helpful for you, Councillor.
If I may, Chair, I think that would be useful, because I think, as I said, looking at the map, the areas where I know where there is significantly high concentrations of that are the very, very similar wards that are highlighted in the darker red throughout that. So, but my concern is that these are housing providers who are taking a lot of money from the taxpayer, who are supposed to be providing care for these people, who quite frankly are not. And it's just, are they engaging with yourselves to try and ensure that these vulnerable people are being supported? Because the only long-term solution to the issues in these communities, but also these individual problems, is actually tackling their substance misuse in the first place.
Okay, Councillor Jones. Make a couple of points. Firstly, the exempt accommodation report is going to coordinating committee, I think, in December. And secondly, in regard to Councillor Moore's point regarding street begging, I just wonder how much you think that's gang driven. And I'm going to give you an example here of when I was in town probably about 5 weeks ago, sitting with my wife talking in the car, black Range Rover turned up, 3 people got out of the back of it and spread themselves around. And we got approached by 2 of those people, one of which, because I hadn't got any cash, I got a card reader. So I'm just wondering how prevalent that is, and how are you aware of the particular gangs that are actually running this process? Because it seems to be a fairly efficiently structured system.
So we're very much part of the Rough Sleeper Initiative, which is a multi-agency approach, and they meet daily and have to be part of those tasking meetings where that intelligence is shared. So yes, we are aware that there is a gang culture, and some of our service users are extremely vulnerable, and they're engaged with us. And what we do is work with them to support them to come away from that culture. And we have seen it, because obviously during COVID, it completely changed, isn't it? The landscape, with people generally moving out the city centre, and now it's come back. So yes, we are aware of it, and we are working collectively with providers to support individuals away from that life.
In view of the vulnerability of a number of these people, and I suspect, I'm not sure what influence some of these gangs may be willing to exert on people, how realistic is it, the potential for people to actually to pull away from that safely while they remain in the locality where they currently are? I suppose I'm saying, how much would we need to physically move those people to get them out of that gang, the influence of that gang culture?
I think it's dependent on that individual, isn't it? And yes, people are end up being accommodated in various parts of the city. But it's difficult, isn't it? Because it's about individual needs. There might be mental health issues. So it's having that whole package of care. What is the best approach for that person? And also that they have that buy-in. Because actually, if you move someone to completely strange part of the city, South Birmingham, I don't know, wherever, that they could end up being extremely vulnerable there as well. So I think it's working with them to empower them to move away, and whether that means, if it's about us working with Trident Housing, for example, to ensure that they are accommodated in a safe place, but they feel comfortable doing that.
And I just think it's worth, we've been up and right in the Rough Sleepers that's the past year and a half, and within that time we've engaged between 200 and 300 new people into our services, and they are coming through the doors, and that they are responding to our outreach offer. But it is Vicky talked about. It's a longer term process to get them to pull away from that and environment.
Thank you, Councillor Jones.
Yeah, basically, Councillor Scotland. So I'm very aware of the issues HMOs, bring with drug addicts, and basically Councillor Moore has stolen my thunder. A lot of the things he's raised, I wanted to raise, but I would like to perhaps say to you, could you do this piece of work then between HMOs and you know, because I think that would be very useful. It seems pointless me repeating what Councillor said.
Yeah.
And also Councillor Brown himself, he's the councillor for Gravelly Hill, so we're pretty hot on these sort of issues. Okay.
Mm-hmm.
I think just to follow up on that particular point, I know a number of the people that come into HMOs and sent accommodation from Gravelly Hill come from prison. So I think it may be some work needs to be done further upstream in terms of what these individuals' issues are before they actually come out.
And I think we're covering a lot of that now with the new prison team, aren't we? Over the last sort of 18 months, where our partners Emerging Futures, Kiki, who's have a special focus on the BME community, are going in and doing work within prison prior to release as well. So when people come out, they have got accommodation, or they are going to go to residential rehab or straight into the service. So I think we will cover it with that. And I think one point to add from me as well is around the work on HMOs is to link in with our colleagues around the new Birmingham City Council landlord scheme as well. You know, they're signing to that charter, just to make sure we link into that as well in terms of any training requirements that there might be or training needs. So Chris, if you want to add something to...
Yeah, I just wanted to, on the traffic light begging, what a better phrase. I think I know that colleagues in the community safety team, community safety partnership, have done an awful lot of work on the traffic light begging, linking with police, linking with us in public health as well, to ensure that where they're identifying vulnerable people who need support, they have ways of getting them into support with organisations like CGL. So I think community safety colleagues may be able to contribute something quite useful to this conversation as well. And I can certainly pick that up outside of this committee meeting, and make sure that we're joining up as much as we can. I know they've run a lot of campaigns encouraging the public not to give money at traffic lights or anywhere else. There's the corporate, there's the online giving scheme if you want to support vulnerable members of the public. And I know they've done a lot of work and putting posters up at traffic. I appreciate that. That may not be making much of a difference as you see it in your areas, but I think community safety colleagues would be part of the solution for that.
Yeah. I think very much so. And for just to remind members, we've actually got the Birmingham Safeguarding Adult Board report here in December. So I think that'd be useful opportunity to develop those issues further. Councillor Hartley.
Yes, I mean, I'm part of the city centre police local delivery group, and certainly drug dealing and related begging and other types of behaviour are high on the priority list. And there's very much a multi-agency approach. And I think we can see that there's no doubt that core activity in the city centre is gang related. Perhaps not the gangs that you might automatically think of. And for my own part, the work that we've been trying to do around the Ladywood roundabout with that semi-permanent begging station that's there, we had it dismantled twice at great risk to waste management, might I add. I think much of that comes from buildings previously known as hotels on the Hagley Road. And you do see the gang masters based around those buildings taking the money from the person and offering them something else. It's not food either. But you see, so there's a network. There's also a public space protection order in action in the core city centre, stretching out to the Middleway, just beyond. Now that we found were really, people didn't want us to involve begging in that as such, but drugs and that sort of antisocial behaviour that stems from it, and dealing and, street crime, street ASB and crime is very much within that order. So that could be deployed to, not to punish necessarily, but to identify and to channel into treatment and a proper life.
Changing the conversation slightly, in terms of the 000 city strategy and the 20-year drugs plan, how much in this will you be looking at kind of further upstream in terms of wider socioeconomics factors as to why people might start getting addicted to drugs or alcohol, and obviously preventing people going down that route in the first place. How much of the procurement, the plan, strategy will be that? And I completely understand that that's a kind of very big, declaration, and social economic circumstances are a very big thing, and you can't kind of solve it all one drugs contract. But how much will you kind of take that into account, and there'll be that in there, or will it be just the kind of service user end that we've kind of heard about in the brilliant work today?
Okay. Thank you,
Just
Councillor.
a second. Could you also respond to Councillor Hartley's comment as well? You've dealt with Councillor Pritchard.
Yeah.
Thank you.
Thank you, Councillor Pritchard. Before I bring Chris in, I think the 000 strategy will have an element of focus on prevention and education as well, because I think you've got to look at things holistically. What's driving them into that sort of treatment environment, and we won't be able to solve everything. That's not within our gift, unfortunately. But I think in terms of partnership working with GPs around education as well, and other key partners, we can do preventative work, and especially around alcohol as well, because alcohol is the big thing, isn't it? In terms of, we have more deaths from alcohol than drugs in Birmingham, so I think there will be that preventative focus. Anything you want to add to that, Chris?
Yeah, partly to reiterate what Carl said, there is a focus on prevention and engaging people earlier on in life. There are elements of working with children and young people, and there's different parts of prevention. There's the general, the universal prevention, and then there's recognising that children living in households where they've got drug and alcohol issues are far more likely to end up with those issues themselves as they get older. So that's a slightly more targeted form of prevention, if you like. So that's all encompassed within the strategy, and importantly, I think the strategy talks about innovative working as well, and trying, obviously following best practice, but also building the evidence base and looking at innovative ways of working to try and achieve different results, better results than what we do at the moment. There's also a lot of mention in the strategy around that sort of joined up approach, ensuring that we're working with colleagues on the mental health agenda, supporting people with mental health issues, mental health needs, to ensure that they are supported provided with the support they need with their situation, so that they're not looking to self-medicate with either drugs or alcohol at a later point. I think hopefully when you see the strategy, you'll see those elements in there, and they are also in the national plan as well. What we have found is, with some of the money that's come from central government to support the delivery of the national plan, as is often the way with these specific grants, they're quite focused. And where we've wanted to do a lot more prevention work, at the moment, a lot of the money that is coming through is around increasing treatment places, reducing caseload, so that people are getting a higher quality support that they need, and the staff are not overloaded as well. But I do think there's room for us to look at that prevention angle more as we go over the next couple of years. Sorry, Councillor Hartley. I'm aware of issues on and around the Hagley Road for a number of reasons. You talked about links to hotels, and you talked about PSPOs at the city centre as well. I have spoken, and a number of us have spoken to colleagues in the community safety team when they've been planning PSPOs, because obviously we want to ensure that people aren't just prevented from being in an area. If they are accessing support services or some third sector organisations, treatment services in that area, it's not going to be helpful just to relocate them or try and relocate them somewhere else. So there are conversations that we have as PSPOs are brought in to ensure that people are signposted into support and treatment and also don't have their current treatment and support network taken away from them if a PSPO is enacted in an area.
One more question, Councillor Pocock.
Probably to the commissioners. We talked about the contract with CGL, but clearly there's a strong overlap with mental health support too. So in the commissioning process, is there anything we need to do to bring those services more explicitly together? Then moving to the providers, I guess, how do you feel about that partnership? Is that working as strongly as it could? And just while mentioning partners, I was interested in Kiki and your other partners. Are they subcontractors to yourselves, or are they commissioned separately? How does the funding to your organisation and to the partners work?
With Datis and Kiki, sorry. Yeah, we subcontract them. Yeah.
Yeah, so Councillor Pocock, taking your second question first, it's sort of an umbrella contract where the CGL and then Datis, Kiki, Emerging Futures and Intuitive Thinking sit below that and are managed by CGL. And I think going back to mental health, as part of the re-procurement process and the commissioning cycle, there'll be a lot of co-production involved in that with key partners, be it the West Midlands Police, the Office of the Crime Commissioner, primary care, the new integrated care board, care system, mental health will be part of that. We've identified those people. I think there's probably 10 or 12 key partners that need to be involved in those conversations based on what the national quality standards that link to the 10-year drug strategy say, and then we can address that work in partnership to make sure all elements are covered. And I know CGL have been doing a lot of work around strengthening that partnership with the Mental Health Trust recently. Vic, I don't know if you want to give.
Yeah, so I think over the last year, I think during COVID it started to really strengthen, but in the last year, our community teams are really linked in with community mental health teams. So we now regularly attend multidisciplinary team meetings that happen weekly in all areas, which didn't happen before. We're very much part of the mental health transformation work, which is really embedded in the south of the city and east of the city, starting in the north and central west, but we're very much connected with that. And so that's operational meetings and strategic meetings. We have jointly reviewed processes with the Mental Health Trust around people who are on wards, inpatient wards, and how they can link in with us in terms of discharge, what that looks like. And we're in the process of reviewing the dual diagnosis protocol that was written back in 2015. And so we've got a number of people from the Trust, from Forward Thinking Birmingham as well, to sit around the table to review that. So I feel like we've really advanced because it's such a fundamental part for us. So many people who use drug and alcohol do it because through self-medication and the balance between services. So we're really pleased with how things are progressing. We know we've got a lot more to do, but I think one of the big battles was just getting people in the same room to have those conversations, and we've really moved on leaps and bounds.
Positive step, Chair, and I think if we can bring in modern slavery, it's clearly a big game going on here.
That's very good point. Thank you all for your time and your report. Could I also ask, I think you mentioned, Victoria, earlier about you work with some HMOs and exempt accommodations in terms of working with them directly.
So we've been asked to go and deliver various training over time to different places.
I wonder if you could possibly send the committee through Fiona or Gail some specifics in terms of the number of
housing providers.
Yeah. You've actually worked there. Thank you very much. I appreciate it.
Thank you for your time.
Right, so work programme, which is the next point we've actually got on here.
Councillor Brown, can I apologise? Something's come up, I've got to go.
Work programme. I think next we've got the adult safeguarding, which I remember looking at, which I think is going to be really useful to us. And And we've got Councillor Khan and Councillor Cotton coming on to discuss the Birmingham Lewisham African Health Inequalities Review, which I think will be really beneficial. And we've got these quarters 1 and 2 adult social care performance monitoring information, which hopefully will be a bit more condensed than it was before. In the January meeting, we've only got one option on the table at the moment, so we may be able to squeeze something else in if anybody feels there's something they'd actually want us to particularly to look at, or when I've spoken to Fiona and Gail, they may have something that would want to slot into that particular area. Councillor Pritchard.
Be an idea to use that slot to do some of the children health environment. I did, as again, because David Melvin earlier kind of was alluded to some of that himself. Yes. Whether having him back specifically on that in that meeting might be an idea as well.
Yeah, that was one of the options that we're looking at. So Gail's looking at the programme for the meetings for the inquiry, which I'm going to take on.
Okay, so any other questions on the work programme?
The question, the data's coming to next month's meeting. We're going to go prior to site of those indicators, right?
The performance data.
Yeah.
My understanding was that Q1 data was circulated to members. If you haven't received that, I'll follow that up. But
if you can arrange for it to be resent, then people have at least got it once.
Yeah, I think there was the offer to bring it to this meeting, but given that the Q2 data is coming to December anyway, I think it was felt it was better to bring it both to the same meeting and do that publicly.
I just missed the first sponsors data. So
That's okay.
If I could just update, to remind members that members of this committee who are involved in the joint HOS, there is a meeting on the 29th of November for the Sandwell and Birmingham HOSC.
That's being held here. Yeah.
That's being held here. And that is the same day that one of the task and finish groups was going to be held. So that won't go ahead because we've got the joint HOSC meeting in that afternoon. So the first meeting of the task and finish group will be into December.
Okay, right. So if there's no other points, date and time of the next meeting is the 20th of December at 10 o'clock. Do we have any requests for call-ins or council call for action? No? Okay. Any other urgent business? No? Do I have your authority to read between meetings? Thank you, Paul. I appreciate it. Okay, thank you all for coming in for your time. I think it's been 2 really valuable sessions today.
I'll just ask for the stream.
Yeah, we'll start.